Hi, I'm Tracy Jensen, and my topic for this week's speech, informative speech, is going to be on neonatal intubation. Now, you might be asking yourself, well, what the heck is a neonate? Neonate is any baby that's 30 days of life or less. But a lot of these techniques that we'll talk about here, you can utilize, in babies that are a little bit older. Say something rolls into your emergency room, a young baby, that sort of thing. It kind of gives you a groundwork or a ground place where to start. So looking at this baby here, you may be, like I said, in the emergency room. Mom rolls in, she's in labor, you don't have anesthesia present, you don't have time for a peds team to get there. What are you going to do? So we're going to talk about how to manage this airway. You can always bag valve mask them, but that's only going to buy you so much time in these little guys. They're going to wear out on you, and you're going to wear out as well. So let's talk about what we need to do. So we know there's differences in the neonatal airway, way different than adults. We already know, obviously, that they're smaller. The airway is going to be more anterior. The epiglottis is a lot floppier. They have big tongues that kind of get in the way, particularly your babies with Down syndrome. They have a larger occiput, which makes positioning real key on these guys. You end up just almost needing a shoulder roll to kind of keep them in alignment in that sniffing position. The narrowest portion of the airway is the cricoid. A lot of people will say, because it's anatomically narrow there, that you don't necessarily need to use a cuff tube. That's kind of beyond the scope of this talk. They have found that in pediatrics they do use cuff tubes, but in the neonates we never use a cuff tube. So why do you want to intubate these guys? Well, if they come in and they're premature, obviously they're not going to be able to maintain their own airway. And oftentimes they need it for what's called surfactant. That is a substance that they usually generate once they get closer to term, that's in the lungs, and it helps keep the alveoli inflated. And that when they were born premature, they haven't often manufactured that on their own, so we give it to them via the tube down into the lungs. You might have a baby that presents with congenital malformations. We're not going to get too much into that right now, but I'll show you a couple pictures of some things that you might run across. Meconium staining, that is when the baby is stressed in utero, may pass a meconium, and then if they come out limp and kind of lifeless, you need to know what to do as far as to get that out of there. Obviously, cardiorespiratory instability on any child. Usually the respiratory instability creates a cardiac instability, because most times if you take care of the airway, then you're going to take care of the cardiac piece of the bradycardia. So these are the kind of things that happen in the delivery room. Maybe afterwards, say you're in a well baby nurse or something like that, the infant becomes unable to protect his airway. You have documented ABGs that are showing you that we're going kind of in the wrong direction. You're hypercarbic, you're hypoxic. And again, therapeutic indications, you can always, a kid can honeymoon for a little bit of time, and then you might need to go back and give surfactant as their O2 requirement increases. So what do you need? I only have limited supplies here, so hopefully you guys are familiar with what a monitor looks like. You're going to have them on a pulse ox on the monitor. Preferably put the pulse ox on the right wrist. It's a preductal sat. You're going to have suction available. Whatever you got is good. If you're going to need to suction down the tube, you're probably going to need a 6 or an 8 French catheter. You're going to need your laryngoscope, obviously a ventilator. If you don't have an infant ventilator, then somebody's going to have to manually ventilate this kid. And then you're going to need your bag valve mask. This is what we call an anesthesia bag. You can use like a regular Ambu type bag. This is nicer because you can, obviously it has to be connected to a source. Preferably O2 and air, so that you can kind of blend, because we don't resuscitate necessarily with 100% oxygen anymore. But this, once it's connected, this will inflate, and you just kind of pinch it off here. You can see here is a manometer, and this kind of gives you a guideline of pressures that you want to go. What pressure do you want? You want a pressure that's going to inflate the chest. You're going to want to see the chest move. You don't need to see a big, huge chest rise. It's very easy to blow a pneumothorax on these kids. Usually real premature infants, about a PIP or a pressure of 20 would be sufficient. And then you're going to have your peak down here that you can see. We usually go around 8's kind of pushing it, so around 5 to 6 for that. So this is kind of a nice little gauge here. This will actually attach right to the endotracheal tube. Here I have here is a 3/0 endotracheal tube, so this kind of gives you an idea. They go from 2.5 to a 4 usually on a neonate. Don't often see a 4 because that's a pretty big kit, and we'll talk about sizing. But this will just connect right onto there. Okay. You may or may not need an IV. Obviously, if it's emergent, you're not going to have time for an IV, and you're not going to worry about doing any kind of induction. You're just going to do it. If it's an elective intubation on somebody, you might consider using some paralytics or sedatives. So laryngoscopes. There's a couple different kinds of laryngoscopes. The ones that are most popular are the Miller and the Macintosh. You can see the Miller is more of a straight blade, and this here is a Miller. This is a 00. This is as small as they come, and they go up to, like, usually I think in the NICU we have up to a 1. So, but these are used a little differently than the Macintosh. The straight blades are going to go right underneath the epiglottis and lift the epiglottis. The curved blades, such as the Macintosh, are actually going to go in the vallecula, which I'll show you in a picture here. And actually, you're going to lift in the vallecula, you're not going to try to scoot the epiglottis with that. So what do you want to do for this when you get ready? Just goes together. Oops, excuse me. Just like this. You want to make sure white, tight, and bright. You don't want a half-lit bulb when you're in there. You want to be able to see what you're doing. So just like that. So where are we going to put this to? Easy rule of thumb is the rule of 7, 8, and 9. 1, 2, and 3. So a 1 kilo infant would be about 7 at the lip. 2 would be 8. 3 kilo would be about 9 at the lip. And that's just kind of a starting point for you. Obviously, you're still going to want to get an x-ray to look for tube placement. You go and listen to your breath sounds, make sure they sound equal, and you get a good chest rise with that. What size do you want to use? Again, this is kind of a gauge. For babies less than 28 weeks or a kilo, you're going to consider a 2.5 tube. Again, I told you we go up to a 4 tube. Any baby that's at like 1 to 2 kilos, you're going to consider a 3. Babies that are 2 to 3, you consider a 3.5, and then for babies bigger than 3 kilos, you can 3.5 to 4. It's nice to have each size available because sometimes you might get a kid that you think you're going to put a 3.0 in, and then it won't pass. There's some sort of edema or something down there. So always have something extra handy. Some people like to use a stylet. I didn't bring a stylet with me today. We actually were not allowed to use a stylet, but you want to make sure that you put it in here, and it's above this here, this Murphy's eye. You don't want it to go past there because you don't want to perforate the trachea. So what do you want to do? You want to position the baby, and I'll show you a position on that. I tried to get my cat to agree to be intubated for this lecture, and he said no. So we're going to have to just look at what we've got on the slides here. So you want to make sure you have your bed at a comfortable height. You got your suction meconium aspirator if you need it. A meconium aspirator is just a little plastic piece that you would pop on the top of the actual top of the tube. And you'll hook it up to your suction. You'll actually use that as your suction. You'll intubate and then pull out. And you're going to do that until the baby's vigorous or until clear, whichever comes first. But we do not, speaking on that, we don't intubate necessarily everybody that's meconium anymore. We find that you're causing more trauma. If they come out and they're vigorous and carrying on, you don't need to do it. It's probably already down there anyway. If they come out limp, apneic, lifeless, then you're going to want to go after it. Don't put your endotracheal tubes under the warmer because then they'll be like rubber and they'll bend and flex and do all those things that will make it very difficult to intubate. We used to actually keep ours in a package, so if you don't use a stylet, we used to actually keep it in the package and actually put it on ice so that it was kind of stiff when we went to use it. Make sure all your equipment's working. Again, we talked about the shoulder roll and the head in the sniffing position because they got this big, the back of their head is real big, so sometimes they can push forward or be really hyper extended, and you want to make sure you have that nice sniffing position that I'll show you here. If you're too hyperextended or flexed, you're not going to be able to see what you're looking for. So here's a good example of what it's going to look like. You'll notice here's the lip. You'll notice you want to stay off that lip. This is the straight blade. So you're going to go down, you're going to actually lift the epiglottis. If you had the Macintosh, you would actually go down in the vallecula and lift. But we're going to go and lift that epiglottis. You'll see here, how we're kind of doing like a toast where you're kind of going toward the corner. You don't want to do this rocking back motion because you're going to get right on that lip. You're going to cut the lip. If you have say a little bit older baby in your emergency room that you're going to try to intubate, they may have a tooth or two, and you certainly don't want to knock any teeth out down into the airway. So what do we want to do? We want to pre-oxygenate. Not necessarily, I should have changed it with 100% anymore. But if that's all you got and you don't have a blender system, then fine. That would be fine to use. If you have a baby that you know is a diaphragmatic hernia, how would you know that? Say that you have a baby that's in a lot of distress, has a scaphoid abdomen, and you hear some bowel sounds up here. You probably have, is in extreme distress, you probably have a diaphragmatic hernia. You want to get those kids intubated right away. You want to try not to bag them before you get them intubated because you're going to blow that gut up and then it's going to press on the lungs even more. Get your monitors on. You're going to insert the laryngoscope blade. Doesn't matter what hand you are, what dominant hand. You're going to use the left hand. You're going to stand above the patient. You're going to put it straight in. And you're going to not visualize the cords at this point. Then you're going to take a step back and lower your head down so that you can see what you're looking at and advance this in until you see what you're looking at. Again, we talked about the straight or the curved blade. If you get in there and you don't see anything and you see, oh, I see like a hole or whatever, but I don't see any epiglottis goes with it, you're too far in. Pull back a little bit. Again, we talked about, do they have a meconium below these cords? What do the cords look like? Are they both moving? You never want to force a tube through closed cords. Structurally, how does it look? Normal. Get your endotracheal tube once you see what you want to look at. One of the things that I was taught, that once you get in there, there's not much mouth to work in here, you know, like you would for an adult. And you don't want to use this as your guide, because then you can't honestly say that you saw it go through the cords. If you get in there, and it's because there's not a lot of mouth, if you give it just a little quarter turn here, you'll have a lot more mouth and lip area to play with, and then you'll be able to actually see it go through the cords. So this is actually what you're looking for. There's your epiglottis, there's your cords, glottis, and then here's the esophagus. Again, if you see this, you need to pull back, you're too deep. So how do we assess placement? Obviously, the best way is to directly visualize that you saw it go through the cords. You can have an end tidal monitoring. You have something like this, it's called a PD cap. Just pop this off. This will actually go on the top of the tube, and then your bag will go on there, and you'll actually bag a couple breaths. If it's purple, there's a problem. It should change to yellow. Yellow is yes, that you're in. Give it a minute or two. Give it a couple breaths, though, because you want to make sure that you have good CO2 exchange. Now, one thing being said, if you have a patient that's in cardiac arrest, you may not have good color changes, and that's just an FYI for you to know. Doesn't mean that you're not in. Use your other ways of checking to make sure it's in, but they may not necessarily generate enough CO2. They might not have that exchange because they're down. You want to see a chest rise. Again, you want to bag them just enough to get a chest rise. You don't want to overdo it. You don't want a pneumothorax to deal with on top of that, because we're not going to talk about needle in the chest here. You're going to listen. You're going to listen in the armpits. Breath sounds radiate everywhere, so you're going to want to get up in those armpits. Endotracheal tube condensation or vapor, not really very reliable, but you may see it. Chest x-ray obviously is your golden to confirm. You're going to just secure that tube to with some tape. You're probably, if you're in a ER or something, you're probably not going to have a special endotracheal tube holder, so just with tape is fine. Don't let go of that tube until you're sure it's secure. And then you assess to see, is your baby improving? Are you peaking up a little bit? How's your SATs? Is your heart rate there? Some problems that we can run into is an esophageal intubation. Again, you intubate, you don't hear any breath sounds here, there's no chest rise, but you hear a honk in the abdomen. You're not in the right place, your baby's not improving, whatever. If you're not sure and you can't verify for sure that you went through the cords, take it out and try again. Your tongue might be in the way. Again, we talked about one of the things, you want to definitely sweep that tongue to the side. And like I said, when you get in there, do like a little quarter turn. And it'll give you a little more room to look. You can't see the cords. Your head is probably hyperextended. You need to get them back more into a sniffing position where everything is in line. If you can't intubate, usually most infants can be bag valve masked pretty easily. Again, it's you know, what you're comfortable with, what your staff is comfortable with. You're going to get tired. You want to make sure that, you know, you guys aren't overdoing it. You're not overzealous. Your heart rate's pumping and you just get real aggressive. Call anesthesia early, but just know that, you know, the golden rule is that you can always bag somebody. It's not necessary always to get fancy. Again, but the baby may wear out or you may wear out and that sort of thing. Let's see. So here's some of the congenital malformations that we talked about. Here's the cleft lip and palate. Here's Pierre Robin. It's where they have a really short jaw. These guys are kind of difficult to intubate. Obviously, this doesn't look like it would be a lot of fun. You can have Apert and Cruzen syndrome, where you have nasopharyngeal airway compromise or maxillary hypoplasia. This golden heart syndrome usually is associated with a lot of airway anomalies. Treacher-Collins, they can have choanal atresia. Stenosis is more common. Down syndrome, they're going to have that big tongue. They might have subglottic stenosis. Laryngomalacia is a congenital abnormality of the laryngeal cartilage. So you can see here it's kind of like an omega shape. And these kind of close in. They don't have a whole lot of tone and they kind of collapse on each other. So that's not a good airway. You might have some laryngeal webbing. You might have a tracheal atresia. This one usually ends up requiring an emergent trach. Don't want to freak you out. Hemangiomas or lymphangiomas here. And we're not going to practice because the cat said no. So that's all I have for you today. Hopefully that kind of cleared up a few things and it wasn't too fast or didn't go beyond what the basics.